Morning, Chris Ohl, Wake Forest School of Medicine, Infectious Diseases, for our late January COVID update. Last week of January. And it's Thursday, so that means we're getting ready for another snow event here in the Triad. Hopefully this one won't be quite as bad. So how are we doing with COVID? Well, I was last here 2 weeks ago, and I said, by the time I come back next week, we will have peaked. And I was right. We did peak. If you're really into the case curves, last Friday, I think. Since then, our case numbers have been coming down in the Triad, as well as in the Triangle, as well as in the Mecklenburg-Charlotte area. Just a little bit of specifics. This time last week, we were knocking on 320 per 100,000 per day, and this morning we're at 225, 230 range. Guilford County, even a little bit lower than that. So those numbers still seem high compared to last year and last year's peak, but we'll take it, won't we? So cases are coming down. I would think they would decrease fairly rapidly for a while, and then I'm predicting a little bit of a shoulder on the curve. And kind of like what we saw with Delta. And they're seeing that in England, and there's a lot of similarities between our communities and those communities in England. So they went up, they came down fairly quickly, and then we kind of have this little plateau right now. But we'll take that too. Is this the light at the end of the tunnel? Is this the end of the pandemic? How do we go to endemicity? So we'll talk about that at the end, so stay tuned for that as to what that might mean. So variants out there, I think Omicron showed us that variants can pop up. But the Omicron variant really surprised a lot of people in science and virology, including myself. And normally when a virus mutates, it drifts. It puts up, single or maybe two mutations in its main spike proteins, and then it drifts from there to the next one, and then from there to the next one. That's how Delta came about. Omicron hit several mutations all at once. Up close to 50, a lot of them in the spike protein, which is why it's immune invasive. And how often is that going to happen? That's probably going to be a more uncommon event. It's not impossible, but the faster we can get the world vaccinated, the faster the world can become immune or partially immune, the less likely that'll be. But we're going to get subvariants, and so right now the one that people are wondering about is the BA.2 variant, which some call the son of Omicron, some call the stealth Omicron. I call it BA.2, and it's really just a subvariant with a few small differences. The big questions is, will this be more immune invasive than Omicron itself? Will it be more infectious? Well, it's probably a tad bit more infectious, otherwise it wouldn't be increasing in incidence compared to its Omicron parent. But it doesn't seem to be an increase in transmissibility that's going to really make a difference for us in either community infections or your own family or personal infections. And it doesn't really seem to behave any differently. So I'm not so worried about it. And I think will it largely overtake the other one? Maybe, probably, but will it mean anything? Probably not. So we'll, learn more about it and any other ones that are coming down the road. So a few studies to talk about that have come up in the last 2 weeks that are of interest. One is we have a better idea now about natural immunity, and both with Omicron and with Delta, With Delta, that's largely history since there's no Delta anymore. We're 99.9% Omicron here in the U.S. And you wave bye to Delta. It's not likely to come back. But what we found was that natural immunity from previous infection was more protective for Delta than we thought it was going to be, and a little bit better than maybe even two-shot vaccination. Probably not any better, and maybe a little less than three-shot vaccination, but we really hadn't been given many boosters back in September and October and August, so we don't really know. But so that's good news. A plug for natural immunity. Yay to our own body's ability to build antibodies to protect us from infection after exposure. The other thing is we found out with Omicron that more about vaccine and vaccine-induced immunity to Omicron. So remember I said just a few minutes ago, Omicron is more immune evasive for previous immunity. And one of the reasons why we're seeing so many infections right now. But it seems that vaccination, particularly a full three-shot vaccination, provides not only more antibodies, but it provides a greater breadth of antibodies than a two-shot vaccine series. That third shot, it turns out, is pretty important. And we've been calling that a booster. Really, let's just call it the third shot because in a couple, 3 weeks, we're going to be labeling full vaccination as a full three-shot series. We've been saying for a long time with our messenger RNA vaccines, it should have been a three-shot series from the get-go, but we didn't know that at the beginning. Now we do. So that third shot is important in increasing the amount of your antibodies, but also the breadth. Because it increases the breadth, it gives it better activity against Omicron than just a two-shot series. How much better? Well, from UK now and Israel and the US and some South African data, it's 60% protective for any symptomatic infection. That means it's 60% protective even for minor COVID colds. Not bad. I mean, that's about what we get out of flu vaccine, and we're happy with that. So 60% protective for COVID colds. But boy, do we have good information now about how protective the whole three-shot series is against severe disease. If you're otherwise a normal host and don't have a lot of other health problems and you're not immunocompromised, you're upwards around the high 80s, 88% is the exact number, protective from getting in the hospital. And your odds of dying are even less than that. So if you look at the curves, and we'll see if we can post that on our social media. I'll put a graph up there for you. That if you've had a three-shot series, you are so much more protected than a two-shot series from hospitalization or death, and immensely more protected than not being vaccinated at all. So when you actually look at the real data, it's pretty impressive. So that's good news. What does that mean about the potential of having to have a fourth shot? Well, it seems like we're pretty lukewarm about a fourth shot, and here's why. Is because while a fourth shot raises your antibody levels, it doesn't seem like, in the studies being done in Israel, it doesn't really seem like it's that much more protective for breakthrough infections. So maybe it'll take 60% and bring it up to 65% or whatever. That's that's a lot of work. It's a lot of resources, and that's a lot of energy to put in for a booster of the three-shot series. So 3 and then a booster to get you a little bit more protection against breakthrough colds. I think we can live with COVID colds. Now, if you're immune compromised, or at the very extremes of age. Maybe that fourth shot might be helpful. So if you're getting cancer therapy or on other drugs, or have had an organ transplant, then the fourth shot's likely helpful. But for the rest of us, I don't think we're going to see it in our repertoire. Now, what we might see is a shot at the beginning of cold and flu season. When's cold and flu season start? Generally around November. What do we do in October and November? We get our flu shot. So we might be seeing a vaccine, and that vaccine might be tweaked a little bit better for variants of COVID, and we'll get it together with our flu shot. A prediction. We'll have to see a little bit more how things go with time, but it wouldn't surprise me. In fact, Moderna thinks that's going to be the deal because they've already worked on and got the COVID vaccine and the flu vaccine and put them together into one. So you only get one needle and you get boosted for both, flu and COVID, at the beginning of respiratory virus season. What else is going on in the world of studies? Most of the other ones are kind of not quite so important, maybe, to the lay public as those two, and so those are the ones I really wanted to highlight. Let's talk a little bit about schools. More and more of a movement to keep schools open and to keep schools as normal as possible, because Omicron scared some school districts into going virtual again. In fact, there's been some talk about some very vocal small minority of people who wanted to see that happen here in Forsyth County. I don't think it is. The only reason a school should shut down is that if they have so many staff members or students out, that it just doesn't make sense to be open. But now with our numbers coming down, I think the likelihood of fewer restrictions. One, for instance, get the music programs back up and going, find a way to do chorus, get athletics up. A lot of school systems have largely done this, but not all have been on board with it. Masking's a little bit more controversial. My personal opinion and my suggestion is that schools should continue to mask until we get significantly over the Omicron surge, just to protect us from student, staff, and teacher absenteeism if they would have an increase in infections and getting sick. So, but I would hope that by the springtime, maybe we could go mask optional. We can talk a little bit about what that might mean. What does mask optional mean? But it largely means doing things to protect yourself if you want to or need to, but then allowing others to not to. So we'll have to see how that transition goes. We're not there yet. So have some patience on that one. Testing's getting better. I know that from seeing more testing sites coming up, and I think we'll shortly have an announcement about some home tests that have been made available for us here in the Triad. We'll be working on distributing, and that's through our county health systems. I think that announcement will be coming out soon. We also have more private testing sites up here at Atrium Wake Forest Baptist Health. We have 3 sites for testing that you can go to. Don't need an appointment. You can drive right in. If you get online and register first, it saves you some time going through the line, about 10 minutes. And so if you want 10 minutes less of sitting in your car, register first. But you don't have to have an appointment. These sites are at the following: here in Winston-Salem, Bowman Gray Stadium, parking lot, and it's open from on Saturdays from 10 to 3, and then on weekdays from 9 to 6. When it's real cold, there may be an hour delay in opening, so you might want to check on that because the people out there swabbing would rather have the sun get a little higher in the sky, warms them up a little bit more. And so Bowman Gray Stadium here in Winston, and Wilkesboro, Lowe's Park at River's Edge, which is out by the old airport. Same hours, 9 to 6 on a weekday, 10 to 3 on Saturday. And then in High Point, Providence Place on Westchester Drive. So the cool thing about this is it doesn't take hardly any time to get through that at all. The lines aren't long. It's being run efficiently. They have a huge amount of capacity. The other cool thing is it's a 24 to 36 hour turnaround for your result. You are not going to get better than that anywhere else in the Triad. I can tell you. You go to CVS or Walgreens, they can't do that. The urgent care can't get that for you. And the emergency room certainly isn't going to get you that. So don't go to the ED to get tested if you're feeling sick or just need to know. Don't go to the urgent care. Let them take care of sick people. Go get to one of these testing sites. It's easy, it's quick, and you'll get your answer a lot quicker, including for those of you who might be contemplating travel and you need a negative test to do that, or you're going to a basketball game and you need a negative test to get in, or you're going to another event, you need a negative test. That's where you should go. Get it there, because you'll get your result back a lot quicker and easier. So, and it's free, even better yet. So thank you for the reminder. That's Joe McCloskey, my media handler in the background. So a little bit at the end here, and we started to talk about this 2 weeks ago, and there's a lot more other people talking about it too. I've been talking about it for a long time. Is after Omicron and the surge quiets down, which it will. What next? And a lot of people are talking about the virus shifting from being a pandemic to an endemic. If you haven't figured it out yet, you're not going to wake up in the morning with a newspaper headline saying pandemic over, COVID gone. COVID is going to just sort of transition and fade in to that group of respiratory viruses that we live with during cold and flu season. And there's a lot of them already. So I guess there's room for one more, and that's the SARS-CoV-2 virus that causes COVID. Likely what that'll mean is that it'll continue to get less severe as we get more immunity in our population. Most viruses, as time goes on and they pop more mutations, their meanness starts to go away some. And there is some hope and optimism that that'll be the case with this one. And as their immunity gets larger, then that means when you get COVID, you get a cold. When you're getting colds, we don't test most of the time. We don't isolate. We don't quarantine. And it is not nearly as disruptive. You know, you take a couple days off from school while you feel sick, you feel better, you go back. That's, I think, the down the road future here for COVID. Will it continue to change? Yeah, there'll be further variants that'll come down the pike. Most of these won't be hugely significant. Our future waves, if we have one, which we probably will at some point, when might that happen? I think the highest likelihood would be, again, the next cold and flu season. Because COVID will still be here, so it'll be part of what will happen during cold and flu seasons. But you know, just like flu, we live with the shift and the changes in flu every year. Maybe we'll be getting a COVID-specific booster in the fall along with our flu shot. That'll help cover some of these variants. The other thing that's going to help us in this transition is the more availability of treatments. So rather than get COVID, get tested, and sit out your isolation time hoping for the best, you'll be able to get therapy. Right now, the ones that have the most promise is sirtuximab, one single monoclonal antibody. The other ones don't work anymore, but that one still does. And the other drug that's kind of exciting is Paxlovid, a drug you get by prescription and take by mouth. The important thing about both of these is that they work best if given early. So as soon as you get sick, if you're of high risk, then you get tested, and then if positive, you can be eligible for those treatments. There's two other treatments we have available, remdesivir, but you have to give that by vein. And if you're doing it as an outpatient, you have to go in and get it by vein three days in a row. And that's a little bit difficult to do, both for the doctor and the patient. And then lastly, there's molnupiravir, which is a drug that has some restrictions, and it's not quite as good as Paxlovid. So the problem is right now are the two most effective therapies, sirtuximab and Paxlovid, are in short supply. They're hard to make. The factories are doing their best, and the supply is going to take a while to ramp up. So just like we did with the vaccine last year, we kind of rationed it out, and there were certain groups of people who qualified over time to get the vaccine. It'll be the same way with these treatments. Right now, we're holding the treatments for those where it would mean the most and where it would make the most difference for their health and who really need it. And that's our immunocompromised patients and patients who have had organ transplants and are immunocompromised, who have cancer and immunocompromised, have certain congenital conditions that make them immunocompromised, and then in a few for extremes of age. So we have a process for doing this within our health systems here, and then UNC and Duke, and down in Charlotte, and Atrium's will be setting their up. Atrium Charlotte will be setting theirs up here shortly. We have ours set up here now in the Triad. And so your doctor actually orders through a committee that drug, and then the committee looks at all of the standards, sees if that's a patient who would really benefit the most from it right now. And then that way we can kind of ration out the drugs so that the people who need it get it. And so that's the process right now. So every month it'll get a little better, and we'll expand the list, just like we did with the vaccines. So by the time we hit summertime, it'll probably be anyone who is at risk of complicated COVID will be available to get treated. So with that, I've mentioned a few things that are going to be happening as we get as we move into endemicity. So how is that going to look? All right, let's pick a potential scenario. Let's say you are 68 years old and you have diabetes and you have heart disease, you would have a higher risk of having COVID. You've had your 3-shot vaccination series. So mostly you're protected from severe disease, but because you have comorbidities and are older, it's not quite as good as if you're younger. So you get sick and you get a fever, body aches, and a cough. You go to your doctor, you get tested for flu, you get tested for COVID, potentially get tested for some other things, other viruses. It ends up, if you have SARS-CoV-2, then you get a prescription for either Paxlovid or one of the other new antivirals that'll be coming out in the near future. If you get flu, you get your flu therapy. So it's going to be a little bit more like what we're used to. You get sick, you get treated. And that'll be out there in the future for endemicity. Unfortunately, we have a little bit of transition here, Ed, and that transition will be a little bit awkward and uncomfortable because we have to start to wrap our minds around leaving a period of time where we do everything we can to not get COVID and entering a time where we live with COVID as a minor infection. Personally, I'm ready for that. I've already wrapped my mind around it, and I'm here to help people also start to think about. So one of the first things we have to do is realize that getting COVID doesn't mean you failed. Doesn't mean you failed to protect yourself. I mean, if your son or daughter got COVID, it doesn't mean you failed to protect your family. It just means that it's out there. Maybe we stop wearing masks at some point once the surges are over, and we decide we'd rather just have a cold. I mean, again, that's going to be down the road. But if you get it, it's not the end of the world. So we have to start thinking a little bit different, and particularly in our workplaces. So for those workplaces where it makes a lot more sense to people have come back to work, once we get through this surge, let's come back to work. For schools, let's have school. Let's try to get rid of as many restrictions as we can for our kids. But the transition's going to be awkward. Just like the transition in going from 10 days of isolation to 5 days of isolation was a bit awkward. CDC had data that said, we can do that. By 5 days, almost everybody's over it. Yeah, there'll be a few, but if you wear a mask after that 5 days, it'll be fine. But I got a lot of criticism. Oh, it's not long enough. It's got to be 10 days. Why are we letting any COVID come back, And this is somewhat like a stepping stone to endemicity. So I imagine as we make changes and guidelines and recommendations change, as we move over the next few months, and it'll be months, into the endemic time, that each one of these guideline changes will also be controversial, and there'll be people who'll push back about it. And then we'll have the other edge of people who just don't care anyway. So we need more of us in the middle. So there's an odd noise in the building, but so with that, I'll go ahead and open it up for questions. Any?
So someone was wondering, how long after having COVID can you test positive?
So how long after having COVID can you test positive? Well, it depends a little bit. It depends how severe your COVID was. It also depends on what test you use. So if you use a PCR test, it can be positive for some time, actually. A small number of people could be positive for weeks, maybe even months. It doesn't necessarily mean you still have COVID in your body. It just means the test is picking up basically COVID cadavers, COVID bodies that aren't capable of transmitting or doing anything. The antigen test is a little different. The antigen test isn't as positive as long, but it is still can be positive longer than what you can transmit to other people, and that's becoming pretty apparent. So let's say you do your 5 days of isolation, you get an antigen test because you just want to make sure you don't have it anymore, but you feel fine, no fever, symptoms are pretty much gone, and you test positive. Does that mean you are still capable of transmitting? Maybe not, because the antigen tests are going to pick up protein pieces that are left over from the infection still. So unfortunately, we have no good available test other than in very strict research laboratories on measuring transmissibility.
I have a question about, with it being probably moving toward the 3-shot series and not so much a booster, is there going to be a situation where, since antibodies wane, that there needs to be like an annual shot, like the flu shot, or how do you handle that?
Maybe. I think that whether or not we have an annual shot like we do the flu shot, is more going to depend on a drift of the virus, which for COVID we call variants. In flu we call it antigenic drift. It's basically the same thing. And that would be the reason where it might turn into an annual shot, actually. But it wouldn't surprise me that happens.
And then last we have someone asking, we know that there can be reinfection of COVID, but is there any information on reinfection with Omicron after you've already had Omicron?
Is there any information on, so we know you can get reinfected after having COVID, particularly a variant. So let's say you got infected early on with what we call the wild type virus, and then Delta came along. The reinfections were a bit higher. With Omicron, they're even higher. But so if you've gotten Omicron, what's your odds of reinfection? After that, we don't know yet. I think and that's really the $1 million question here, because the durability and robustness of the immunity from Omicron is going to tell us a lot about what endemicity is going to look like. So we don't know yet.
We actually just had one special request come in. Apparently this person's mom, Diane, who's 80 and immunocompromised, watches you every week, and it's her birthday. And she wants to know if Dr. Ohl can wish Diana a happy birthday. Happy birthday, Diana. Yes, I'd be happy to do that. And I hope you have many, many birthdays to come. So happy birthday, Diana. Oh, the other thing I need to mention, and I don't know why I thought about it now. I had a great discussion with Algernon Cash, who heads up, I think it's, if I remember the term, Eat Drink Triad, eatdrinktriad.com. And this is our food and drink trade association in the area. And we had a really nice webinar together for his people. Frankly, our restaurants are hurting, and January is a slow time anyway. Because of Omicron, people got skittish about going out to eat again and being indoors eating, and so we've had some restaurant closures, some that have been prominent and have been around for decades, and so I wanted to talk a little bit about that. First of all, now is the time. Pick up the phone and make your February and Valentine's Day reservations and go out to eat. I really think Omicron will be at a point in the next couple weeks where people can feel safe going out to eat again, particularly if you've had 3 shots. There's no reason to not go. So let's go. Let's start making these reservations and support indoor dining again as Omicron fades into February. The other thing is, go get some takeout. A lot of places are doing takeout now. And if you're sick of heating up chili at home, get some takeout. Let's support our foods and drinking establishments. They need it. We need them. And I really want to put a plug in for them. And they've been quite patient and working hard trying to get through this. So with that, I'll see you next week.